Hello everyone. I'm audible and visible to all of you guys. Please update me in the comment section. Thank you. So let's begin, guys. Welcome to the PSM part 2. We have already done with the part 1, and I hope you guys have revised the part 1 as well. Okay, so today we'll have a final part. We'll try to cover up all the left topics. So be interactive enough, okay? And let's get the PSM part 2 done, okay? So meanwhile, any doubts, any questions, you're welcome to ask. Clear? Okay, and followed by PSM part 2, we'll be having pediatrics 4-hour session on 16th of July. Okay, so till then, keep revising OB/GYN part 1, part 2, PSM part 1, part 2, and all the remaining videos from the rapid revision MeduHub. Okay, so let's begin with the first question of the day. Okay, and day by day you have to be more confident because exams is coming closer, just few days away. So let's start. As per the national immunization schedule, which vaccines are indicated at the first visit for the immunization of a 13-month-old baby who has not been previously immunized? Okay, so if the baby has missed the vaccination and the age of the baby is 13 months, the age of the baby is 13 months. Now, what are the following vaccines we can give up till the age given? Okay, so very important question from the delayed vaccination schedule. Okay, we have already discussed from our main sessions as well. If we talk about the first vaccine, that is BCG vaccine, the BCG vaccine can be given up to 1 year. Okay, BCG vaccine can be given up to 1 year. Okay, first we'll clear this particular topic and then we'll get back to the given question. Okay, if we talk about the rota vaccine again can be given up to 1 year. Followed by that, IPV can be given up to 1 year. If you talk about pentavalent dose first, up to 1 year. So the vaccines that can be given up to 1 year are BCG, RVV, IPV, and pentavalent first dose. Okay, if we talk about pentavalent second and third dose, it can be given up to 7 years. It can be given up to 7 years. Pneumococcal vaccine again can be given up to 1 year. OPV, MR and MMR up to 5 years. Up to 5 years. DPT can be given up to 7 years. And Japanese encephalitis up to 15 years. Up to 15 years. So remember, guys, remember BCG, RVV, IPV, pentavalent first dose, and PCV. These are the vaccines that can be given up to 1 year. These are the vaccines that can be given up to 1 year. Okay, and the question is that the age of the baby is 30 months. The age of the baby is 13 months. That's more than 1 year. So which of the following vaccine you can give? So already BCG is gone. Okay, first option A and option C is already ruled out because BCG can be only given up to 1 year. The age is 13 months. That's how you rule out these options. First, remember the age up to 1 year. Followed by that, if you know that we just mentioned that the pentavalent first dose can be also given up to 1 year. So this is gone as well. So what are the vaccines that we can give? So vaccines that we can give is OPV first dose, DPT first dose, and the measles first dose. So option D is going to be the answer. Is that clear to everyone? Yes. So delayed vaccination schedule is important. Okay, you have to remember what are the vaccines. So remember up to 1 year, what are the vaccines? So BCG, RVV, IPV, pentavalent first dose, and the PCV. These are the vaccines can be given up to 1 year. Followed by that, so the vaccines that can be given up to 5 years, OPV, MMR, vaccine can be given up to 7 years, pentavalent second and third dose, and DPT, and Japanese encephalitis can be given up to 15 years. Japanese encephalitis can be given up to 15 years. Clear to everyone? Yes? Okay, let's move to the next question. An infant was brought to the PHC for immunization. He was vaccinated by the nurse who reconstituted the vaccine with the sterile water before the administration. Which among the following vaccine the nurse has likely administered? Okay, now diluents of the vaccine we have discussed again. Now the infant was brought for the immunization and the nurse reconstituted the vaccine with the sterile water, the normal water. Okay, now which vaccine is reconstituted with sterile water? Write down in the comment section, guys, everyone. Yes, this is a time for the active recalling. You guys have to be interactive, whatever you have studied from last couple of months. Okay, yes, very good. Chalo, very good. The answer is MRB. Okay, let's talk about the diluent of the vaccines. Okay, if we talk about the normal saline is the diluent for BCG vaccine. So it's for BCG vaccine, it's for yellow fever and dengue. Okay, BCG, yellow fever and dengue. If we talk about the Japanese encephalitis, the diluent of the vaccine JE is phosphate saline buffer. JE is phosphate saline buffer. Okay, and if we talk about distilled water, that is measles rubella, that is MR, measles rubella. Okay, and the vaccines available in the liquid form, they do not need diluent. Okay, what are the vaccines? We have DPT, we have Hep B, and we have TT. You have DPT, Hep B and TT. You have DPT, Hep B and TT. Okay, now the doses of vaccine, if we talk about dosage, DPT, Hep B, influenza, measles, Japanese encephalitis, the dosage is 0.5 ml. If we talk about BCG, 0.1 ml, IPV 0.5 ml, OPV we give 2 drops which is equivalent to 0.1 ml. RV, rotavaccine, again the oral vaccine, we give 5 drops which is equivalent to 0.25 ml. Is that clear? So it was about diluents of vaccine and the doses of vaccine. Remember, MR is a vaccine which has been reconstituted or diluted with the sterile water. Clear? Followed by that, if we talk about the National Universal Immunization Program, what are the vaccines that are given at birth? You remember the mnemonic. So Bob is given at birth. What is Bob? So hepatitis B, OPV and BCG. Hepatitis B, OPV and BCG. And remember the vaccines that can be given up to 1 year. BCG will be in the options. Remember, always rule out the other options with the help of a BCG. That will be helpful for the delayed vaccination schedule. Okay, now if we talk about the 6 weeks, 10 weeks and 14 weeks, you already know we give the pentavalent vaccine, pentavalent 1, 2, 3, 4 and 5. Sorry, pentavalent contains of 5 vaccines. We give pentavalent 1, pentavalent 2 and pentavalent 3, that is 6 weeks, 10 weeks and 14 weeks. Followed by that we give OPV 1, OPV 2, OPV 3, then we give rotavaccine 1, 2 and 3 and fractionated IPV 1, and at 14 weeks fractionated IPV 2. Okay, so let's write at 6 weeks what are the vaccines we are giving. So we are giving OPV 1, okay, followed by we are giving pentavalent 1 containing the 5 vaccines, diphtheria, pertussis, tetanus, Hep B and influenza B. Okay, we are giving RV 1, okay, we are giving vaccinated PV 1 and we are giving pneumococcal vaccine 1. Okay, if we talk about at 10 weeks, so we are giving OPV 2, pentavalent 2 and rota vaccine 2. Okay, at 14 weeks we are giving OPV 3, we are giving pentavalent 3, we are giving rota vaccine 3, fractionated PV2 and PCP2. Okay, at 9 months we are giving MR1, we are giving Japanese encephalitis 1, we are giving fractionated IPV3, and we are giving pneumococcal vaccine booster. Also we are giving vitamin A around 9 months, vitamin A around 9 months. If we talk about 16 to 24 months, we are giving MR2, Japanese encephalitis 2, okay, we are giving DPT booster 1 and OPV booster, okay. 5 years we are giving DPT booster 2, and then 10 to 16 years we are giving tetanus toxoid. This is about the universal immunization schedule. This is about the universal immunization schedule, okay. Now followed by that next question, okay. Epidemiology is the study and analysis of the distribution, patterns and the determinants of the health and the disease conditions in a defined population. Which among the following correctly defines the generation time in an epidemiology? Now simple question about a definition will come, okay. Multiple questions have been asked on based upon these definitions. Now simply, which of the following will define the generation time? Again, this has been the question asked in NEET PG 2024, okay. It's a PYQ. So tell me which among the following will describe the generation time. Very good. Yes, correct. So generation time is defined as the interval between the entry of organism till the maximum infectivity. It is defined as the entry of an organism till the maximum infectivity. This is called as generation time. It is called as generation time, okay. Now let's discuss about the other definitions that have been given in the option. Interval between the marriage and the birth of the child. This we have a phases of the family cycle. So from the marriage till the birth of the child, this is called as formation. This phase of family cycle is called as formation. Clear to everyone? Yes. Followed by that, if we talk about the interval between primary and secondary case, this is called as serial interval. Again a PYQ FMG. It is called as serial interval, okay. If we talk about the interval between the entry of infectious agent and the symptom of the disease, this is called as incubation period. So it's called as incubation period. P is period, okay. If we talk about the entry of an infectious agent till the detectable antibody present, if we talk about an entry of an infection till the detectable antibody present, your answer goes to, yes, comment section mein batao what will be the answer. If entry of infection to the detectable antibody present, so that is called window period. That is called window period. Clear to everyone? So we have formation, we have generation time, serial interval, incubation period and window period. These are all the important definitions, okay. One more definition they can ask about quarantine, and one more they can ask about the quarantine and isolation. About quarantine and isolation, okay. Now if we talk about a quarantine, if we talk about the quarantine, it means the separation of, let me write it clearly. So what is quarantine? It means the separation of healthy or suspected person. It means separation of healthy or suspected, okay, till incubation period. Till incubation period, that defines the quarantine. If we define the isolation, sir, isolation means the separation of the diseased person. Separation of diseased person till period of communicability. It means the separation of a diseased person till the period of communicability. Is that clear? So this is all about the different definitions that have been asked multiple times. Interval between marriage and the birth of a child is the formation. entry of an organism till the maximum infectivity or till the period of communicability, it is called a generation time. Interval between the primary and the secondary case, that's going to be the serial interval. Interval between the entry of an infectious agent and the symptom of the disease, that's going to be incubation period. Interval between the entry of infectious agent and the symptom of till the detectable antibody present, that's going to be the window period. Okay. Quarantine is defined as the separation of the healthy or suspected people till the incubation period. For example, for the COVID-19 for 2 weeks, 14 days. Isolation, it's a separation of a diseased person till the period of communicability. For example, measles, 4 days before the rash, 5 days after the rash. Again, that has been a question asked in your exams. Clear to everyone? Yes? All the people out there? Chale, next, now let's discuss about the family cycle. The families are not constant, they are ever changing, and they have 6 phases. Okay. Now, if we talk about the formation of the family cycle, formation phase of the family cycle, it begins with the marriage. Okay. Formation begins with the marriage and till the birth of the first child. Okay. The question can be asked that in a family, there is after the marriage, there is a birth of a first child. The family enters into which phase of family cycle? Are you getting my point? Yes, the question has been asked that after the birth of a first child, the family will enter into which phase? So birth of the first child, the family will enter now. From the birth of the first child, they enter into the extension. Remember guys, so what is extension? From the birth of a first child till the birth of the last child. From the birth of the first child till the birth of the last child, that's going to be the extension. Okay. Then we have complete extension, that is birth of the last child, first child leaves home. Complete extension, we have birth of the last child, first child leaves home. Okay. Followed by that we have contraction, first child leaves home, last child leaves home. That's going to be contraction. Last child leaves, the first spouse dies, that's complete contraction. And first spouse dies, the death of the survivor, that is a dissolution. Is that clear? So we have 6 phases: formation, extension, complete extension, contraction, complete contraction, and we have the dissolution. Clear to everyone? Yes? Chale. Next question. Maize is deficient in which of the following amino acid? Okay. Now, maize is deficient in which of the following amino acid? Write down in the comment section. Okay. Now, let's discuss about the food and the amino acid deficient. Okay. If we talk about maize, maize is deficient in tryptophan. Maize is deficient in tryptophan and lysine. Maize is deficient in tryptophan and lysine. Okay. So next, if we talk about pulses, you remember with the PCM, P is pulses, C is cysteine, and M methionine. So pulses are deficient in cysteine and methionine. Clear? Okay. Next one, if we talk about wheat, wheat is deficient in lysine and threonine. Wheat is deficient in lysine and threonine. Next, if we talk about cereals, it's deficient in lysine. It's deficient in lysine. Okay, as you all know guys that tryptophan से क्या क्या आता है? Tryptophan, niacin is also coming. Okay, along with that, what else is coming from the tryptophan? Serotonin and melatonin. Okay, serotonin and melatonin. If the question will be asked that 1 gram of niacin needs how much of tryptophan? 60 mg of tryptophan. Remember, 60 mg of tryptophan is needed to produce the 1 gram of niacin. Okay, and you already know that niacin deficiency will have a pellagra-like symptoms. Okay, so usually when a case of pellagra symptoms will be given, they will mention the maize eater. Clear to everyone? Yes. Chalo, let's move to the next part. So which of the maize is deficient in which of the following amino acid? What will be the answer? So it's gonna be both A and B, lysine and tryptophan. That's how you remember. MLT. MLT. What is MLT? Maize is deficient in lysine and tryptophan. Maize is deficient in lysine and tryptophan. Okay, clear? चलो आगे बढ़ते हैं. Now the upper class score in a Kuppuswamy scale is, now you already know that there is a scale which measures the socio-economic status in the urban areas, and the name of the scale is Kuppuswamy scale, having three parameters. Okay, now what exactly are the three parameters? Yes, we have income, we have occupation and education. Okay, now based upon this scale, the score of total 29 is there, and we have a different parameters and for the different types of class. Okay, so let's discuss what exactly is Kuppuswamy scale. Chalo, what is Kuppuswamy scale? So it is a scale which tells us about the socio-economic status. It tells us about the socio-economic status of urban areas. Okay, and what are the components? So components are income, occupation and education. Income, occupation and education. Income, occupation and education. Is that clear? Income, occupation and education. Okay, now if we talk about the class of an Kuppuswamy scale, the upper class is 26 to 29. The upper class is 26 to 29. Okay, middle upper is a score of 16 to 25. Okay, then we have middle lower 11 to 15. Then we have lower upper 5 to 10. We have lower 0 to 5, and the total score is 29. Total score is 29. So as per the given question, the upper class is 26 to 29. The upper class is 26 to 29. Okay, so that's about Kuppuswamy scale. Okay, next question. The CBR of a population. The CBR of a population is 19 and the CDR is 6. Find the annual growth rate. Find the annual growth rate. Okay, now if we talk about the growth rate, it is CBR minus CDR divided by 10. Okay, that is the formula for the annual growth. Okay, so here it's 19 minus 6 divided by 10, which is 13 by 10, which is equal to 1.3%. Is that clear? So the annual growth rate is 1.3. The annual growth rate is 1.3. Clear? The annual growth rate is 1, and this is the old annual growth rate of the country, 1.3. But if you talk about the recent updated data, okay, few things you need to mention, guys. Few things you have to mention. Let's write it down. Okay, first of all, as per the SRS 2025, the first thing, write crude birth rate. As per the new data, it is going to be 19.3. As per the new data, it's 19.3. Okay, followed by rate, if we talk about crude death rate, it's going to be 7.5. It's going to be 7.5. Okay, I'm writing here 2025. It's going to be 7.5. Okay, if we talk about the next growth rate, the growth rate is 1.18%. The growth rate is 1.18%. The growth rate is going to be 1.18%. Okay, if we talk about the infant mortality rate, okay, that's going to be 27. Infant mortality rate, that's going to be 27. Okay, if we talk about neonatal mortality rate, that's going to be 19. Neonatal mortality rate is 19. Okay, maternal mortality ratio, MMR, maternal mortality ratio, remember, that's going to be 93. That's going to be 93. Maternal mortality rate, if the question comes, maternal mortality rate, that's going to be 6.0. Is that clear? Yes. If you talk about goal of a maternal mortality ratio, that is less than 70. The goal MMR is less than 70 by the year 2030. By the year 2030. That is about a recent updated data. That's about a recent updated data. Is that clear? Is that clear to everyone? Is that clear to everyone? Yes. Chalo. Now, if a question has been asked on a crude death rate, for example, how do you calculate crude death rate or crude birth rate? If the question has been simply asked on crude death rate or crude birth rate, now the crude death rate question has been given. Look at the question. In a town with a population of 800,000 people, there were 7,200 deaths recorded in a year. What is the crude death rate? What will be the crude death rate? Okay, tell me guys, what will be the crude death rate? So what is the formula for the crude death rate? You already know. So the total deaths upon the total mid-year population, multiplied by 1000. That is 7,200 by 800,000 multiplied by 1000. Clear? This and this is gone. It's equal to 9. So that is 9 deaths per population. That is 9 deaths per population. Is that clear to everyone? Yes. So what will be the answer? So CDR will be 9 deaths per population. Clear? So how do you calculate CDR? So total deaths by total population given multiplied by 1000. So total deaths were 7,200, followed by that 800,000 where the total population multiplied by 1000. Gone. 0 0 is gone. 8 ones and 8 9 is 72. That is 9 deaths per population. Clear to? Yes. So the simple calculations they will give. They will not give the complicated calculations in which you need more than 1 minute. Yes. All you need is to remember the formula. Okay, remember the formulas. Okay, and then it's easy to solve. Okay, now one more question for you guys from the CDR. Please tell me, in a country with a population of 3 million people, there were 45,000 deaths recorded in 1 year. What is the crude death rate for this country? Please write down in the comment section, everyone out there. Yes, so calculate total deaths as 45,000, population is 3 million, multiplied by 1000. What will be your answer for this? What will be the answer, guys? Write down in the comment section. What will be the answer for this particular question if the question has been asked on a crude death rate? Yes. So you have a population of 3 million, 45,000 deaths. Calculate the CDR. Your answer is going to be total deaths upon the population multiplied by 1000. Very good, Venkat Siva. Very good. You're right. The answer is going to be 15 deaths per 1000 people. 15 deaths per 1000 people. Very good. Excellent. Okay. Now, if a question has been asked, on the infant mortality rate, if the question has been asked on an infant mortality rate, now how do you calculate the infant mortality rate? Yes. Write down, how do you calculate the infant mortality rate? Yes sir, number of infant deaths per 1 lakh live births, that is will tell you about the infant mortality rate. That will tell you about the infant mortality rate. Okay, so number of deaths is 2000 per 1 lakh live births multiplied by 1000. That will tell you about the IMR. Okay, so write down the formula, guys, and tell me the answer. Yes, so how many deaths, infant deaths? 2000 infant deaths upon how many live births per 1 lakh live births multiplied by 1000. Yes, very easy. So what is the answer, bachcho? Tell me, what will be the answer? The answer is going to be 20. The answer is going to be again, answer is again B. Answer is 20. Okay, so how do you calculate? What is the formula? So infant deaths divided by per 1 lakh live births multiplied by 1000. The answer is 20. So the IMR is going to be, the IMR is going to be the 20. The infant mortality rate is going to be 20. Is that clear to everyone? Yes, is that clear to everyone? How to calculate CDR, CBR and infant mortality rate? Yes, all good, guys? Can we move to the next question? Okay, let's move to the next question. So please do remember this all data. The question that they can ask, 19.3 is going to be the current crude birth rate, 7.5 is going to be crude death rate, annual growth rate is 1.18, infant mortality rate is going to be 27, neonatal mortality rate is 19, maternal mortality ratio, okay, maternal mortality ratio is going to be 93, maternal mortality rate is going to be 6.0, and the goal for maternal mortality ratio is less than 70 by the year of 2030. Remember, in maternal mortality ratio, the denominator is live births, and in maternal mortality rate, the denominator is a reproductive age. The denominator is reproductive age group. Okay, chalo आगे बढ़ते हैं. A cardiologist wants to study the effect of a drug, atorvastatin, a drug which is a hypolipidemics, which lowers the level of cholesterol. He notes down the initial cholesterol level of 50 patients and then administers the drug. Fine. After a month's treatment, he measures the cholesterol level again. Which of the following is the most appropriate test the statistical significance of the change in the cholesterol levels? Okay. Now we have discussed about a type of a data. We have two types of data. One is going to be a quantitative data. Another one is going to be a qualitative data. Okay, bachche? So one is quantitative data, another one is qualitative data. Now what is quantitative data? So quantitative data means the data that can be measured. Quantitative data means the data that can be measured. So what is qualitative data? Qualitative data मतलब होता है जो data आप measure नहीं कर पाते हैं, ठीक है ना? Now we have a different types of test. A part of a test that is for the quantitative data where you can measure a test, a test called as non-parametric test, which is for a data we cannot measure, that is a qualitative data. Okay, now if we talk about the cholesterol levels, it is which type of data, guys? Yes sir, we can measure the cholesterol levels. It is a type of a quantitative data. Now in quantitative data we have two types of tests. We have student t-test and we have ANOVA test. In student t-test we have two types. If you are comparing a same group before and after intervention, it's going to be a paired student test. If you are comparing two different groups, that is going to be unpaired student t-test. If more than two groups are being compared, that's going to be a ANOVA test. So let's write and understand how exactly to choose whether the test you are going to choose is a parametric or a non-parametric, and depending upon the groups. Clear? So first of all, remember, sir, if we talk about a parametric test, these are the tests which are used for which type of data? So they are used for quantitative data. They are used for quantitative data. Okay, and in quantitative data, sir, we have two tests. Number first test, we have a student t-test. We have student t-test, And next one we have is ANOVA test. Now in student t-test, what are the things? Two tests we have. In student t-test, bache, we have some paired student t-test, and we have unpaired student t-test. Now let's understand what is paired and what is unpaired. Okay, now for example, the scenario that has been given to you, listen to carefully, bache. We have a one group of 50 people. Okay, this is a group A of 50 people. Okay, these 50 people have high cholesterol levels. Okay, they are having 250 cholesterol levels, and for these 250 cholesterol levels, for this particular level, I'm giving a drug atorvastatin or rosuvastatin, so that the cholesterol levels will be decreased. Okay, now I'm giving a treatment for 1 month, or I'm giving a treatment for a full 45 days course, and after 45 days I'm again calling these same 50 people, please come, and I'm going to check the cholesterol level again. So my dear students, before the intervention, that means before I'm putting this test up, the test of significance, I'm checking the blood cholesterol levels of these 50 people. After administering this drug using of 45 days, again I'm comparing these 50 people. So when you are comparing a same group before and after the intervention, such type of tests you will use is a parametric test. And which parametric test you will use when you are talking about only one group? Your answer is going to be, sir, paired student test. Your answer is going to be paired student t-test. Okay, and if now there are two groups, both of them have high cholesterol levels. One group you are going to advise that go for the lifestyle modification, control on the sugar levels, control on the diet, don't eat fatty food, oily food, spicy and all. Please minimize these things. Okay, next group you are giving a drug, okay, atorvastatin, and after 1 month you are comparing between two groups. You are comparing the cholesterol level between two groups. The first group that has been taking the medication atorvastatin, and the second group that is going for the lifestyle modification. So when you are comparing between two groups, the test that you use for a quantitative data, it's going to be unpaired student t-test. That is going to be unpaired student t-test. Is that clear? Is that clear? So student t-test, paired and unpaired. So paired is for one group, unpaired is for two group. Unpaired, two words, unpaired, two groups. Okay, and if more than two groups are there, the test that we use is going to be the ANOVA test. The test that you do is going to be ANOVA test for more than two groups. For more than two groups. Is that clear? Is that clear? Very simple. So first of all, we'll check the quantitative data, and eventually they will mention, okay, you have to calculate what? Mean or standard deviation. Okay, in the questions usually what they will mention, please do check mean and standard deviation. So it will be hint given as well. Whenever you see mean and SD has to calculate, it is a type of a parametric test that you use. Anyway, it could be a student t-test, that is either paired or unpaired. If sir one group, I am going to mark the answer as a paired. If sir two groups, I am going to mark the answer as an unpaired. And if sir more than two groups for the quantitative data, I am going to mark the answer as ANOVA test. Okay, now here in the question, before and after the intervention, here in the question, my dear students, before and after intervention, checking the cholesterol levels. Cholesterol is a type of a quantitative data which can be measured. So the type of the test I'm going to do is a paired t-test. It's going to be paired t-test. Is that clear? Is that clear to everyone? What exactly is a paired t-test? Clear to everyone, please? Yes. Now one more question I will show you based upon this only, so that it will be easy for you to understand. Okay, now check. Now look at this next question. Blood pressure of three different groups A, B and C. Now first of all, you need to find which type of data it is. Now bache, blood pressure can be calculated. Yes sir, blood pressure can be calculated. So blood pressure is a quantitative data. So which type of test? Parametric test. So parametric test, एक group होगा तो paired. सर दो group होंगे, unpaired, sir, दो से ज़्यादा होंगे, that is going to be the ANOVA test. So blood pressure of 3 different groups A, B, C was measured and the mean blood pressure was calculated out of it. I have told you over there, mean and standard deviation you have to calculate from the parametric test. Okay, now 3 means are different. The most appropriate test to determine the significance of difference between the mean is, so test of significance for more than 2 groups A, B and C. So 3 groups are there. What is the type of the test bache you will use? So we are going to use the ANOVA test. We are going to use the ANOVA test. Okay, so ANOVA is for more than 2, paired is just for 1. Okay, and then chi-square and other scientists, they are for the non-parametric test. So parametric test is clear. Now let's discuss what exactly is a non-parametric test. So if we talk about the non-parametric test, so in non-parametric test we have, first thing, it is for which type of data? It is for qualitative data. So it is, sir, it is for qualitative data. So we have qualitative data. Okay, now first thing, in qualitative data, if you have one paired group, the test you will use is a sign test. Okay, one paired group. Okay, followed by that we have one more test called as chi-square test. Okay, it is either for 2 unpaired groups or more than 2 groups, that is chi-square test. Okay, so sign test and chi-square test. Now remember that, my dear students, that in non-parametric tests, it is a type of a test for a qualitative data in which you cannot calculate, so you just have to check percentage or proportion. So percentage and proportion, non-parametric test, chi-square test and the sign test. Okay, is that clear? What exactly are the different types of tests? So yes, if a question is asked, the test of significance done for 2 or more proportions. Now you know non-parametric test. Okay, so 2 or more than 2 proportions, which non-parametric test you will use? So the answer is chi-square test. The answer is chi-square test. Clear to everyone? Clear to everyone? Chi-square test. So that's how you will mark whether the test you are going to do is a parametric or a non-parametric. But the first thing you need to check, is सबसे पहले क्या check करोगे आप? So the first thing we need to check is a type of a data, whether the type of the data is a qualitative or whether the type of the data is a quantitative. Whether the type of the data is a quantitative. Clear? Clear to everyone? Yes. चले आगे बढ़ते बच्चे. Good. If you want to check the incidence of the deafness caused by the noise in the office workers and the factory workers after 1 year, which type of study will be conducted? As discussed in the part 1, when you are going in a future, when you are going in the forward direction, when you are going from a risk factor to disease direction, this study is called as a cohort study. This study is called as a cohort study. Okay, and then that time I've already told you what are the strength of association is given by, sir, the strength of association is given by the relative risk, population attributable risk, okay, and attributable risk. Clear? Chale. So let's understand what exactly is a cohort study. Okay, now we have already discussed about cohort study in the previous one, so let's go a bit quicker in this. So this cohort study, it's also called as forward looking study. It's also called as forward looking study. It's also called as forward looking study. Okay, followed by that, it's also called as cause to effect study or a risk factor to disease study, or the risk factor to disease study. Clear? Or the risk factor to disease study. Okay, now if we talk about this cohort study, as I've already discussed, my dear students, that it needs more time, it needs more money, and the continuous follow-up is needed. That is a disadvantage, because sometimes we can lose the follow-up as well. But the different outcomes can be studied comparatively to the case control, which is a quicker, which does not need any follow-up, okay, which is not time consuming, which is fast, and other things. Okay, now the classical example, okay, always that we give in case of a cohort study. For example, patient is going for smoking for last 10 years, and eventually we'll wait now for a lung cancer to study that what is the risk of lung cancer to the people who are smoking. So smoking is going to be the risk factor, and the lung cancer is the disease. So classical example is going to be smoking to lung cancer. And as studied earlier, the strength of association is given by relative risk, we have attributable risk, and we have population attributable risk. Okay, so this is about a cohort study. Okay, now if we talk about a relative risk, sir, how exactly is this relative risk? How exactly is this relative risk calculated? It is calculated incidence in exposed, incidence in exposed by incidence in non-exposed, by incidence in non-exposed, incidence in exposed by incidence in non-exposed. So we have people here, guys. Smokers, these are the exposed people. Non-smokers, these are the non-exposed people. Okay, now a study was conducted to assess the association between the smoking and the lung cancer. The following data was collected. Okay, now we have total of 100 people, in which 100 people are smokers. The lung cancer present was 60, and 40 people no lung cancer. Okay, we have 100 non-smokers, among which 20 got cancer and 80 cancer was absent. So how do we calculate? How do we calculate the relative risk? So what will be the relative risk for developing lung cancer among smokers compared to the non-smokers? So it's going to be incidence in exposed divided by incidence in non-exposed. Okay, now let's calculate, guys. Use the formula. So first of all, we'll calculate incidence in exposed. So incidence in exposed, how many people are totally exposed? Sir, 100 people. Out of 100, how many people develop the lung cancer? 60. So incidence is exposed is 0.6. Is that clear? Incidence in exposed is how much? 0.6. Okay, now if we talk about incidence in a non-exposed, sir, incidence in non-exposed, sir, total of 100 people are there as well, but only 20 developed lung cancer. So non-exposed people, how many develop lung cancer? 20 people. So do the calculation, bache. So that is going to be 0.2. That is going to be 0.2. Clear? Now total incidence now calculated. It's incidence exposed by incidence non-exposed. Now incidence is equal to 0.6 divided by 0.2 to 1 to 3. That is 2 3s are 6. That is going to be 3. So how much is the incidence? So that is going to be 3.0. That's going to be 3.0. So what is the answer? The risk of a cancer in smokers is 3 times more than the people who are non-smokers. That's how you calculate the relative risk. Very simple, sir. Incidence in exposed by non-exposed. First see incidence in exposed, how many people are total out there and how many develop the condition. That will give you incidence exposed. Followed by that, calculate the incidence non-exposed. See how many total people out there and how many develop the disease among the non-exposed, and then calculate it, okay, by exposed by non-exposed. That is 0.6 by 0.2, that is 3.0. That means the chances of the cancer, okay, are 3 times more in smokers compared to the non-smokers. Is that clear? Is that clear? Do you got it now? How exactly to check the how exactly to check the relative risk, please let me know in the comment section. Yes, everyone out there, all good? चले आगे बढ़ते बच्चों. Yes, some mixed study designs when you combine the cohort study plus case control. Okay, so we have first one called as a retrospective cohort study. The direction is forward for the study, but we go back in time 10 to 20 years, and from the hospital records or the data we can find out the exposed or non-exposed people or the data. We check in current time how many of them have currently disease, exposed or non-exposed. Clear? Then we have mixed cohort. It simply means the direction is forward, but you go backward. That is retrospective. Then again you go forward. So retrospective study plus you do the forward study again for next 10-20 years. That study is called as mixed cohort study. Simply means that retrospective cohort plus prospective cohort. That is, if we do another study for 10 to 20 years in forward direction after the retrospective cohort study. After the retrospective cohort study, that is going to be the mixed cohort study. That's going to be the mixed cohort study. Clear? So that's all about the relative risk. Okay, chale. Next question. A woman in an age group of 25 to 45 years. She's 10th pass. She's married or divorcee. She belongs to the same village community with the well communication skills. She is selected by the village personnel. She is eligible to work as. She is eligible to work as. So again, a PYQ, such is eligible to work as a ASHA. The full form is accredited social health activist. Accredited social health activist. Okay. Now we talk about first the grassroots level workers, the village workers. Okay. Now we have ASHA, accredited social health activist. We have AWW, Anganwadi worker. We have TBA, which is a trained birth attendant, and we have VHG, village health guide. We have village health guide. Okay. Now the question was asked that out of the following, which of the following is not a village worker? Okay, not a village worker. I will tell the answer here as auxiliary nurse midwife. Okay, auxiliary nurse midwife. So that is not a, it is not a village worker. It is not a village worker. Okay, now let's discuss about this village workers. As you all know that the location is a village level. So it works in the village. ASHA also at the level of village. And Anganwadi worker, it's also at the level, but which center? ICDS. Okay, ICDS center. Okay. Now if we talk about first one by one, trained birth attendant, the population norms is 1 per 1 village. So it's 1 per 1 village. Education for the trained birth attendant, sir, it's not required. There is no education required. The training duration for 1 month, that is 30 days. Okay, and she's trained by multi-purpose worker and she's trained by medical officer. Okay, multi-purpose worker, female and medical officer. That is about a trained birth attendant. That is about a trained birth attendant. Okay, if we talk about the village health guide, village health guide as per the population, it is 1 per 1000. Okay, the education required is 6th standard pass. The training duration is 3 months, and she is trained by a medical officer. She is trained by a medical officer. Okay, if we talk about ASHA, population norms is 1 per 1000. Yes, for ASHA 2 per 1000 is desirable. Okay, chale. Then the education should be 10th pass. Training duration for Asha is 23 days, and she's trained by Anganwadi worker. She's trained by multi-purpose worker female, and she's trained by medical officer. Okay. Followed by that, Anganwadi worker, guys, depending upon the hills and plains, the population norms for Anganwadi worker, if talked about the plains, (800) for plains, and if talked about hills, it's 1 per hills. Okay. Education, sir, it's 12th pass. Training duration for 4 months, and is trained by community development project officer. Community development project officer. So it is about the village workers. It's all about the village workers. Okay. Now if you talk about the functions of Asha, okay, remember guys, Asha, first of all, she's a part of a JSY scheme, Janani Suraksha Yojana. She's a part of a JSY scheme, number first. Number second thing is she does the home delivery of contraception. Home delivery of contraception. Number third, she gives the treatment for the minor ailments. Treatment for minor ailments. She goes for the active disease surveillance. So what is active disease surveillance? When type of surveillance, when a health person or the health worker are going to home by home and give the treatment for the disease and or the diagnose the disease. What is passive surveillance? When a diseased person is coming to the hospital and takes the treatment. And one more is a sentinel surveillance, that is exclusively for the what? That's exclusively for the sexually transmitted diseases. Clear? And remember one more condition. What are the disease they are going for? Sir, Asha is going for filariasis. Asha is going for leishmaniasis. Okay, for TB as well. Chale. So that is about the active disease surveillance. One more thing, guys. Remember, Asha do not conduct deliveries. Which of the following will be incorrect about the functions of Asha? The question will be mentioned. They do not conduct deliveries. Yes, they do accompany a female patient who is pregnant to the hospital. Okay, Asha, but they do not conduct deliveries. ठीक है ना? चले. Next, that is all about the functions of Asha. Chale. What is the recommended vaccination schedule for the post-exposure prophylaxis for rabies in a previously vaccinated individual? Very important question, guys, about the rabies vaccination. Okay, now tell me, there can be 3 scenarios in the rabies patient. First of all, sir, a patient who wants to get vaccinated before bite, pre-exposure prophylaxis, or a patient who's already vaccinated and got a dog bite, scenario number second, or a patient who's not vaccinated at all. So you have 3 scenarios. Okay, and recently one kabaddi player, a 21-year-old guy who passed away because of the rabies. Okay, he somehow saved a dog from somewhere scrap, जहाँ से भी उठाया उसको, and eventually he got a scratch, but he did not went for a full vaccination, and eventually what happened? He got rabies, and you already know the case fatality rate of rabies is how much? It's 100%. Okay, so CFR of 100% that after you get the symptoms, once you got the rabies, it's eventually gonna take your life. Okay, so very important one. And now the schedules for the rabies that have been asked in three scenarios. Either the pre-exposure prophylaxis, that means before the bite. Okay, sir, patient was not vaccinated, how many vaccines will give? So patient was vaccinated, but still, what will be the schedule? So let's understand first about a dog bite. So class 1, we have grade 1, grade 2 and grade 3. That's what you call class 1, class 2 and class 3. What is grade 1 dog bite? So grade 1 dog bite means when there is just a lick on the intacted skin, okay, unbroken, there is no bleeding, no scratch, nothing, a dog licks. So the only management is that you should wash extensively with soap and water for 15 minutes, nothing to do at all. Okay, if there is scratch without blood, give the local wound management plus vaccine. Okay, and if we have a class 3 bite, that means the multiple scratches are out there which causing the loosening of the blood, the lacerations or unknown wild dog bite. Okay, for that what you have to do, give the local wound management, vaccination along with the rabies immunoglobulin, okay. So grade 1, grade 2, grade 3. Grade 1 suggests reassurance and wash. Grade 2, so wound management plus vaccination. Grade 3, so we need to give vaccination, immunoglobulins and the wound management. Okay, now if a patient is coming to you for a pre-exposure prophylaxis, so pre-exposure prophylaxis, so patient is coming before bite. So we'll give 3 doses. So day 0, day 7 and the booster on 21 or 28. So how many doses we are giving, sir? We are giving 3 doses. Okay guys, now followed by that post-exposure prophylaxis. Now post-exposure prophylaxis, patient was not vaccinated at all. We have 2 regimes. So we have SN regime which is given intramuscular. Sir, how many doses are given? Bache, sir, 5 doses are given. So what are these 5 doses? On day 0, 3, 7, 14 and 28. We have 0, 3, 7, 14 and 28. That is going to be the post-exposure rabies vaccination schedule as per the SN regime. Okay, if we talk about a next regime, that is Thai Red Cross regime. It is given intradermal. Sir, how many doses? 4 doses. And what will be the schedule? Sir, day 0, 3, 7. So need to skip the 14th and 28. That is about the as per the Thai Red Cross regime. Please do remember guys, post exposure as per intramuscular 5 doses, 0, 3, 7, 14, 28. Thai Red Cross as per intradermal 4 doses, 0, 3, 7 and 28. Now post exposure prophylaxis, if less than 3 months, okay, wash the wound, nothing has to be done. Okay, so if more than 3 months, we'll give 2 doses. What are the 2 doses? 0 and 3. What are the 2 doses? 0 and 3. Okay, so here what is the recommended vaccination schedule for the post exposure prophylaxis for rabies in the previously vaccinated individual? Okay, like take it more than 3 months, it's not mentioned in the question. So wound cleaning, what will be the answer? So we go for the wound cleaning plus ARV on day 0 and 3 plus ARV on day 0 and 3. Clear? ARV on day 0 and day 3. Clear to everyone? Yes, so that is about a rabies that is about a rabies pre-exposure and post-exposure schedule. Okay, along with that we will give rabies immunoglobulin as well, 14 international unit per kg. Okay, clear? So about the rabies, tell me which protein is helping in the transmission of a rabies virus. Rabies is a which type of virus, sir? It is a type of a virus called as Lissa virus. Remember about rabies. Okay, first thing. Second thing, the intracytoplasmic inclusion bodies in rabies are called as, कौन सी bodies होती है बच्चे? Sir, we have Negri bodies. Number second point, rabies virus which shape? A bullet shape. Number third point. Number fourth, case fatality rate is 100%. Okay, chalo. Number third point, first site of Negri bodies is horn of hippocampus. Horn of hippocampus, you will found the Negri bodies. Okay, case fatality rate of 100%, and the protein responsible is dynin for the transmission, that is going to be dynin. Is that clear? Is that clear? Okay, so it's all about the rabies virus. Lissa virus, the bodies are Negri bodies, first found in horn of hippocampus, second site to be found is cerebellum. Okay, and rabies, once patient is having rabies, they have what? Hydrophobia as well. You might have seen they have hydrophobia as well. So it is all about the rabies. Okay, so remember, case fatality rate of 100%. We have Negri bodies, first found in horn of hippocampus, second found in cerebellum. Okay, dynin is a protein which responds for the transmission of the virus. Okay, and also once there is a grade 3 wound, do not go for the dressing, because if you do for dressing, we cover it up, the virus can go deeper. Okay, usually we keep it open for a while. Okay, then hydrophobia, remember 3 doses, 0, 7 and booster on 21 or 28, 3 doses, 5 doses as per the SN regime, post exposure prophylaxis not vaccinated, 4 doses as per the Thai Red Cross regime, and 2 doses as per the post exposure vaccinated one. Okay, day 0 and day 3. Is that clear? Is that clear? And sir, if there is no bite in 3 years, then again you need to repeat the booster dose. Okay, so less than 3 months, wash the wound, more than 3 months, 2 doses, and then repeat after 3 years. Clear? Chale, next question. Arrange the stages of demographic cycle of a country given below in the correct order in which a population of a country shows the transition over a period of time. Okay, so you need to arrange it. The demographic cycle, we have discussed the phases of a demographic cycle as well. So first we have a high stationary, followed by we have a low stationary, we have early expansion, then we have a late expansion, and then we have a low stationary and the reversal. Okay, now each one of the following depending upon the birth rate or the death rate. In high stationary, when we talk about the stationary, that means the population is not going to change. So the population in case of a first phase and the fourth phase is going to be same. Okay, then depending upon the early and late birth and death rate. Okay, now if we talk about the first one, high stationary, the birth rate in high stationary is very high, and the death rate also is very high. So eventually what will be the population size? The population size is going to be stationary. The population size is going to be stationary. Okay, in early expansion, the birth rate is high. The birth rate is high. The death rate starts decline. The death rate starts decline. The population size start increasing. The population size start increasing. Okay, in case of late expansion, we have birth rate which starts decline, we have death rate which continue decline, and population size, it will increase but the slow rate. The population size will increase with the slow rate. Okay, we have low stationary. the birth rate is very low, the death rate is very low, both of them are low, the population size is going to be stationary. The population size is stationary. Okay, reversal, the birth rate is almost zero, the death rate, there will be unnatural deaths, and the population will be decreasing. The population will be decreasing. Okay, so this, we talk about India. India is in the third phase, which is late expanding or late expansion. Okay, now if we talk about the sequence of this, that is going to be 1 high stationary, then early expansion, then late expansion, and then low stationary. That's going to be 1 3 4 2. So answer is going to be option D. What will be the answer, bache? Very good, answer will be the option D. Clear? Chale, next question. I've already done this question about parametric test, more than 3 groups, quantitative data, that's going to be ANOVA test. Okay, chale, in a train accident there were 74 dead, 4 were severely injured, 15 moderately injured, and 22 mildly injured. Color coding in a triage from highest to lowest category is, color coding from a triage, color coding in a triage from highest to lowest category is. Okay, so what is triage? In tagging, there is a segregation of a patient based on chances of survival with the best possible treatment available, but not on the basis of the severity or illness. Okay, so we have 4 groups based upon the chances of survival. We have first group red, sir, then yellow, green, and black. Okay, so you have to remember the sequence, very simple way: red, yellow, green, black, RYGB, RYGB. Okay, now if we talk about the red color has been given the highest priority. So highest priority kisko dete bache? Highest priority given is red color. Okay, and these are the people who need a life-saving surgery or resuscitation within 0 to 6 hours. Within 0 to 6 hours. Okay, yellow is given a medium priority. Yellow given a medium priority, in which the surgery or resuscitation is needed 6 to 24 hours. 6 to 24 hours. Okay, followed by that we have green. These are the people with a minor injuries. Green में क्या है? People having a minor injuries, and these people are given low priority. These people are given a low priority. Then we have a black color. Okay, black color में क्या है? Given a least priority. Green, we have least priority. These are the dead or the moribund patient, which are about to die. Which are about to die. These are the patients which are about to die. Okay, so what is the sequence? Sir, sequence is RYGB, that is red, yellow, green, and black. Red, yellow, green, and black, in which a red is given a highest priority, and the least priority is given to the black, and the least priority is given to the black. Clear हो गया बच्चों? Yes. चले आगे बढ़ते. Choose the incorrect statement in a given table for the vaccine strains. Okay, now choose the incorrect statement. BCG Danish 1331, that's going to be correct. Yes sir. Yellow fever is 17D, correct. Measles is Edmonton Zagreb, correct. Rubella Oka, no. Rubella ke liye we have RA27/3, and the Oka, sir, Oka is for chicken pox. Oka किस लिए? Sir, Oka is for the chicken pox. Oka is for the chicken pox. Chalo. Next, now let's write about the vaccines. Let's write about the vaccines and the strains. Let's write about the vaccines and the strains. Okay, now first vaccine is going to be the first vaccine is going to be the influenza. What is the name of the vaccine strain for influenza? That is going to be A7 2009 caliph. Okay, followed by that we have yellow fever, which is 17D. Okay, followed by that we have Japanese encephalitis live, that is SA 1414-2. We have Japanese encephalitis killed, which is Nakayama. We have BCG with Danish 1331. Okay, we have Rota vaccine, we have R11XX414, that is going to be Rota vaccine. We have mumps, which is Gerelin. We have measles, Edmonstron Zagreb. We have rubella, RA273. We have rubella RA273. Okay, we have chicken pox. Okay, that is Oka strain. That is Oka. Okay, chicken pox or varicella zoster, same. We have IPV, Salk. We have OPV, we have Sabin. Okay, so these are some strains of vaccines. So here the incorrect one is rubella Oka. Rubella is RA273, while as Oka is the chicken pox. Okay, all of the following constitutes demographic process except. All of the following constitutes demographic process except. So among the following, which one of the following will not include the demographic process? Yes, A, B, C, D. Tell me the answer. Yes, very good. So it's going to be the morbidity. It's going to be the morbidity. So write it down. Okay, so what are the 5 demographic processes, and what are the 5 demographic processes? Write it down in the comment section, guys. What are the 5 demographic processes? Chalo, write down in the comment section, everyone. What are the 5 demographic processes? Yes, 3 are in the option also: fertility, migration, social mobility. Yes, write down, everyone, in the comment section what is the answer. What are the 5 demographic processes? Yes, we have fertility. Write down, we have fertility, we have migration, we have social mobility, we have marriage, and we have one more, we have mortality, and we have mortality. Okay, so let's write it down. So we have 5 demographic processes. So what are the 5 demographic processes? Number 1, it is going to be the mortality. Okay, number 2, it's going to be to marriage. Followed by marriage, we have fertility. We have migration. And we have social mobility. And we have social mobility. Very good. Marriage, mortality, fertility, migration, and social mobility. Okay. Now we have indicators of demography. What is demography? It's a study of population. Study of population. Okay. Now we have different formulas: CBR, CDR, GFR, GMFR, TFR, GRR, and NRR. Okay, we have discussed all these things. For now, we have discussed crude birth rate, crude death rate, GFR. Okay, now tell me what is the current value of CBR and what is the current value of CDR? जल्दी जल्दी बता दो comment section में. What is the current value of CBR and CDR? Everyone, what is the current value of CBR and CDR? Yes, just now we have discussed in the recent update crude birth rate and crude death rate. What are the new values? बता दो जल्दी जल्दी. Yes, 19.3. Yes, very good. 19.3 is going to be the crude birth rate. Very good. And crude death rate कितना है? Yes, 7.5. Very good. That's going to be 7.5. What will be the annual growth rate, बच्चों? Tell me anyone. What will be the annual growth rate? What is the new annual growth rate? Before it was 1.3, but now it is 1.18%. But now it's 1.18%. चलो आगे बढ़ते. So crude birth rate. What is the formula? So number of live births. So it is number of live births by mid-year population multiplied by 1000. So the current is 19.5. Number first thing. Next, 19.3. Okay. Next, sir, crude death rate. It's number of deaths by mid-year population into 1000, and it's going to be 7.5. So general fertility rate, it's total number of live births upon mid-year population of which group? Reproductive age group, that is 15 to 45 multiplied by 1000. Okay, that is general fertility rate. Now general marital fertility rate, it's total number of live births. It's total number of live births by mid-year population of a married people, 15 to 45 age group. Okay, then we have a total fertility rate, which is defined as the total number of live children born to a woman in her entire reproductive period. Okay, we have gross reproductive rate. G is gross, G is girl. So we have total number of girl children born alive to a lady in her entire reproductive period. We have NRR, total number of girl children which is remaining alive till their own reproduction. Okay, that is NRR. If the question is most important demographic vital indicator, that is NRR, because if the girl will remain alive, then only she'll be able to reproduce. That's why it's the most important vital indicator. The only demographic fertility indicator which will include the mortality, that is again the NRR, because the mortality is only included in NRR. The mortality is only included in NRR. चले आगे बढ़ते हैं. The Alma Ata Conference 1978 was conducted with a theme to discuss on primary and essential healthcare of a country. All of the following are the principles of primary healthcare except. All of the following are the principles of primary healthcare except. Okay, so let's discuss about the principles of primary healthcare. What are the 4 principles of primary healthcare? We have equitable distribution. So we have equitable distribution, number first thing. Number second, we have intersectional coordination. We have intersectional coordination. Okay. Third, we have community participation. We have community participation, and we have appropriate technology. We have appropriate technology. So among the following, which one will be the answer? So it is appropriate policy. Okay, so which of the following except is given? So except, it is policy. So in real, it is what? Appropriate technology. It is appropriate. It is appropriate technology as the answer. Clear? So if we talk about the elements of the primary healthcare, we have 8 elements. So what are the 8 elements of PHC? We have the mnemonic elements only, where E is education. E is education. Okay, which education, guys? Health education. Then we have L, which is locally endemic diseases. L, sir, is locally endemic disease. Okay, followed by that we have E is essential drugs. We have E, which is essential drugs. Okay, then we have M. M is going to be mother and child care. M is mother and child care. Okay, we have E, which is I, immunization. I, immunization. N, that is nutrition. We have T, treatment of common diseases. Treatment of common diseases. Okay, and we have S, safe water supply and sanitation. We have safe water supply and sanitation. So it's all about the healthcare system of India. We have 8 elements and we have 4 principles of the primary healthcare. We have 4 principles of the primary healthcare. Okay. Next question, guys. A case control study is a type of an observational study in which 2 existing groups differ in outcome are identified and compared on the basis of some supposed causal attribute. All of the following are the advantages of case control except. So case control study, you already know that it's a backward study. It's a retrospective study, which is from a disease to risk factor, or which is from a outcome to effect. Okay, now out of the following are the advantages of the case control study except. Now except is which one? The one question that we already solved a few minutes before, guys. So relative risk, it is actually calculated in which study? So it's calculated in the cohort study. Okay, not in the case control. In case control is useful for the rare disease. Yes, nested case control studies are used for the rare disease in which the causative agents are not known or the tests are so expensive. The odds ratio or the cost product ratio can be calculated. Yes, it is calculated in the case control study. So it's cost effective and inexpensive. Very good. Yes, sir. Case control study is cheap because you don't need the continuous follow-up and you don't need to do investigations. Okay, so all of the following are correct except relative risk. Yes, sir. Relative risk is going to be calculated in the which type of study? That is going to be calculated in the cohort study. That's going to be calculated in the cohort study. Okay, now let's summarize the 4 studies here only. First one is cohort, then it's case control, then we have a cross-sectional, and followed by that we have ecological study. Followed by that we have which study? Ecological study. Okay, now if we talk about the first study, that is the cohort study, direction of the cohort study is going to be the forward. So the direction of cohort study is forward. Okay, if we talk about case control, the direction is backward. The direction is backward. Cross sectional, the direction is at point. The direction is at point. Ecological, again the direction is at point. The direction is at point. Okay, now forward direction we have a cohort study, backward we have a case control, at point. Okay, neither forward nor backward, which is also called as a snapshot study, that is going to be cross sectional study, which gives us about the prevalence of the disease. And ecological study, again, which is done at a point time, which will tell us about the characteristic of a population, usually done for the nutritional surveys. Okay, now among the following, if we talk about the importance, this followed by this. Okay, this is going to be the importance among these four, but the best study is going to be, the best one is going to be the meta analysis. The best one, bache, is going to be the which one? So best one is going to be the meta analysis. Okay, followed by that, if we talk about unit of study, okay, unit of study in case of cohort, case control and cross sectional is going to be individual, while if we talk about a cross sectional study, well, if we talk about an ecological study, the unit of study is going to be the population. So unit of study in case of a cohort study is going to be individual. But in case of ecological, it's going to be population. It's going to be the population. Okay, if you talk about the parameters, what are the parameters? Relative risk, attributable risk, and the population attributable risk. These are the parameters calculated in the cohort study. Case control mein we do calculate the odds ratio. We calculate the odds ratio. In case of cross sectional, we check the prevalence, and the ecological study, it will tell me about the characteristic of population. Okay, so it is all about the different types of study: cohort, case, cross sectional and ecological. Cohort, case, cross sectional and ecological study. Okay, chalo. Next question. A 3-year-old baby was brought to the hospital with the complaints of fever, severe diarrhea, abdominal pain and vomiting. On history taking, the mother revealed that the child was vaccinated recently, and the examination revealed a sausage-shaped lump on palpation. Which vaccine was given to the child, which has led to these adverse events? Now, talking about the side effects of the vaccine or the adverse effects of the vaccines, post-vaccination, it was seen that a baby is complaining of fever, diarrhea, abdominal pain and vomiting. And upon the examination by the doctor, there was a sausage-shaped lump on the palpation. Okay, this sausage-shaped lump, okay, classical diagnosis of intussusception. So, bache, intussusception, tell me in the comment section, intussusception is a side effect of which of the following vaccine? Intussusception is a side effect of which of the following vaccine? Okay, yes, good. Intussusception, C, rotavirus vaccine. Very good, it's a rotavirus vaccine. Now, adverse events following the immunization. We should ideally observe a child for at least 30 minutes. Okay, now we have a different vaccines and their side effects. Okay, if we talk about the first side effect or the adverse event, which is paralysis. Paralysis is due to the OPV, oral polio vaccine. If we talk about a hypersensitivity reaction and the shock, that is going to be hepatitis B. That is going to be the hepatitis B. Okay, then toxic shock syndrome, that is measles vaccine. Toxic shock syndrome is due to the measles vaccine. Okay, then GBS, that is due to the killed influenza. GBS, it is due to the killed influenza. Okay, Guillain-Barré syndrome, also caused by Campylobacter jejuni. Okay, so GBS will be given in a history directly. They will not mention GBS. They can mention there is a gait instability or there is areflexia. So your diagnosis, areflexia, instability goes with the GBS, and the answer is killed influenza. The answer is killed influenza. Chale. If we talk about intussusception, this is going to be rota vaccine. Intussusception is going to be the rota vaccine. Febrile seizures, that is measles vaccine. Febrile seizures, it's measles vaccine. Persistent crying, that is going to be pertussis. That's going to be pertussis. Thrombocytopenia, MMR. Neurological complications, that is going to be DPT. Okay, we have also scar lymphadenitis by BCG vaccine. Scar lymphadenitis, which vaccine will cause that? So that can be caused by BCG vaccine. That will be caused by BCG vaccine. Chale. So adverse reaction post the vaccination. Okay, so this is a case of intussusception, red currant, jelly stools, target sign. Okay, intussusception, and this is a case of which vaccine side effect? Rota vaccine. Chale. Next question. A 32-year-old female, para 3, life 3, visit a gynecology OPD for the contraception. On examination, you notice there is a foul-smelling vaginal discharge. There is a foul-smelling vaginal discharge. Which of the following contraceptive method is relatively contraindicated in this case? So patient coming to you with a foul-smelling vaginal discharge, you are suspecting a patient can be the case of a pelvic inflammatory disease. So PID is there. Okay, so PID will be a relative contraindication for which of the following contraceptive. So your answer is going to be yes. Write down in the comment section what will be the answer. Write down in the comment section what will be the answer. So the answer is going to be IUCD. Answer is going to be intrauterine contraceptive device. So you know that we have a relative contraindications. We have a relative contraindications and absolute contraindications of IUCD. So let's discuss what are the relative contraindications and let's discuss what are the absolute contraindications. Okay, now first of all, these are the different types of the intrauterine contraceptive devices here in given below. First of all, this contraceptive device, it is a Mirena, which is a hormonal containing IUCD containing levonorgestrel. Okay, and the lifespan of this is going to be 5 years. And this is which generation IUCD? Said it is going to be 3rd generation IUCD. Is that clear? So Mirena containing a progesterone. Okay, also used in abnormal uterine bleeding. Okay, and then it's a 3rd generation IUCD. Clear? Now followed by that we have a second one. This is going to be a copper T 380A. This is going to be the copper T 380A. This is a copper containing 2nd generation IUCD where 380A is the surface area, and the lifespan of this copper T is 10 years. The lifespan is 10 years. Okay, then the previous year question that has been asked, it is a 1st generation IUCD called as Lippies loop. Okay, and this is a 1st gen IUCD. It's not used anymore. Clear? It's not used anymore. Chalo. It was all about the generations. Now let's discuss about the contraindications. So in contraindications, bache, we have 2 contraindication types. So what are the contraindication? First, we can have absolute contraindication, and then the second one we have the relative contraindication. We have absolute contraindication and we have relative contraindication. If we talk about an absolute contraindication, what is an absolute contraindication? That is suspected pregnancy. Okay, if you are suspecting the pregnancy, okay, that is going to be the absolute contraindication. Number second, if a patient is having a current PID, if a patient is having a current PID, okay, remember, if there is a history of PID, that is going to be the relative contraindication, but the current PID is going to be the absolute contraindication. Okay, then patient is having undiagnosed bleeding per vaginal. Undiagnosed bleeding per vaginal. Okay, and fourth one is going to be the patient having a cancer cervix, patient having any adenoma or pelvic tumor that is going to be the absolute contraindication. That is going to be the absolute contraindication. Okay, sure, you can put up the question. Chalo. Then we have a relative contraindication. So what is the relative contraindication? Okay, now you know that the side effect of IUCD after the intrauterine contraceptive device is inserted, patient complaining of heavy bleeding is the most common side effect. Okay, that's what you call menorrhagia. अब patient को ज़्यादा bleeding हो रहा है, patient is already anemic. Now after patient is having a heavy bleeding in a patient who is an anemic, so it will be a relative contraindication. Already blood levels are less, already there is anemia, and once you are putting IUCD, more anemia will occur. So that is a relative contraindication number one, that is anemia. Okay, that is anemia. Okay, followed by that because of anemia में क्यों हो रहा है? Because of menorrhagia, sir. No need to write, you know, because of, I will write that in the side effects, anemia. Number second is patient having history of ectopic pregnancy. Patient having history of ectopic pregnancy. Now you know that ectopic pregnancy most common cause is pelvic inflammatory disease, but IUCD can be also the cause of an ectopic pregnancy. Number third thing is patient is having history of PID. Patient is having history of PID. Okay. Number third thing, patient is having any purulent cervical discharge. A cervical discharge coming. Patient is having uterine malformations like septate uterus, bicornate uterus, or patient is having fibroid. Okay. Congenital malformations or fibroids. Okay, or we have unmotivated person, or we have unmotivated person. So these are about the absolute contraindication and the relative contraindication. So this is about the absolute contraindication and relative contraindication. Clear? Now if we talk about, sir, IUCD, okay, सबसे पहले if there is IUCD, okay, and there is pregnancy, so I will write here pregnancy with IUCD, pregnancy with intrauterine contraceptive device. Okay, now patient is pregnant, okay, and the intrauterine contraceptive device is inside. What is the first step to do? Sir, remove the IUCD. Okay, remember always first you have to do remove the IUCD. Okay, if not able to locate this. Okay, remember, if inside the uterus, if this intrauterine contraceptive device is inside the uterus, sir, how to remove? You remove with the hysteroscopy. You remove with the hysteroscopy. If outside the uterus, you remove with the laparoscopy. You remove with the laparoscopy, hysteroscopy and laparoscopy. Clear? So pregnancy with ICD, remove the ICD first, and if inside the uterus, hysteroscopy, outside the uterus, laparoscopy. Okay. Now if we talk about the side effect of the intrauterine contraceptive device, the most common side effect, most common side effect is menorrhagia and polymenorrhea. Okay, and when a patient is having menorrhagia and polymenorrhea, okay, what will be the treatment? So post IUCD patient is complaining of heavy bleeding along with the frequently. Okay, what is menorrhagia? More than 80 ml. What is polymenorrhea? Sir, less than 21 days. Okay, so what will be the management? Management, remember bache, you will mark sir reassurance plus folic acid or iron supplements. Okay, reassurance plus folic acid. Okay, then followed by that, second most common side effect, menorrhagia. Then we have pain as a side effect. Patient is having pain. Okay, and pain is the most common cause for removal of IUCD. Most common cause for removal of IUCD. Okay, then it can cause PID as well. Okay, it can cause uterine perforation. Okay, it can cause ectopic pregnancy. It can cause pelvic inflammatory disease. Okay, now patient is having pain, that means infection can be out there, and what you will do, sir, remove the ICD and start antibiotics. Remove the ICD and start the antibiotics. Clear? And pregnancy with ICD I've already discussed over here, that how to approach further. Clear to everyone? Yes, is that clear to everyone? Yes sir. Okay, so let's recap whatever we have studied and then take a short break and then further. Chale. We started with the first question of the day, that is the delayed vaccination schedule. Okay, so what exactly is the delayed vaccination schedule? Now, if the age of the baby is up to 1 year, the vaccines that can be given is BCG, RBV, IPV, pentavalent first dose, and pneumococcal vaccine. These are the vaccines, 5 vaccines that can be given up to 1 year of age. If it is OPV and MMR, it can be given up to 5 years. If the pentavalent second and third dose is there, and the DPT, it can be given up to 7 years, and Japanese encephalitis can be given up to 15 years. Okay, followed by that, we discussed about the diluents of the vaccine. Remember, the BCG, yellow fever, and dengue vaccine is a normal saline, phosphate saline buffer for the Japanese encephalitis, normal water for MR, and vaccine that do not need any diluent, that is DPT, Hep B, and TT. Okay, now doses of the vaccines: 0.5 ml for DPT, Hep B, Hep, measles, JE. BCG is 0.1, IPV is 0.5, OPV 2 drops, RV 5 drops. Okay, then the universal immunization schedule, you already know. The definitions: the interval between the marriage and the birth of the child is the first phase of the family cycle, that's going to be the formation. The entry of an organism till the maximum infectivity is going to be the generation time. The interval between the primary and the secondary case is serial interval. The entry of an infection till the symptom of the disease is incubation period. Till the detectable antibody present, it is going to be the window period. If there is a separation of a healthy or suspected person till the incubation period, that is quarantine. until the period of communicability, that is going to be the isolation. Okay, then different phases of a family cycle we have discussed: formation, extension, complete extension, contraction, complete contraction, and dissolution. Okay, now the maize is deficient in which amino acid? That is going to be lysine and tryptophan. Okay, lysine and tryptophan with maize. We have pulses, cysteine and methionine. We have wheat, lysine and threonine. Cereals, we have lysine. Remember bache, 60 mg of tryptophan is needed to produce the 1 gram of niacin, Then the Kuppuswamy scale, it is a scale which is used to tell us about the socioeconomic status of urban areas, having a 3 components: so income, occupation, and education. Income, occupation, and education. The total score of 29 is there, and the upper class is 26 to 29, while as the lower is 0 to 5. Okay, the recent data: crude birth rate, okay, 19.3, crude death rate 7.5, growth rate is 1.18, infant mortality rate is 27, neonatal mortality rate is 19, maternal mortality ratio is 93, maternal mortality rate is 6.0, and the goal of MMR is less than 70 by the year 2030. Okay, then we discuss about the parametric and the non-parametric test, in which we have student T test and the ANOVA test. Student T में 2 है अपना, paired student T test for the 1 group, unpaired 2 groups, and ANOVA test for more than 2 groups. We have qualitative data, sign test for a 1 paired group, chi-square test 2 unpaired and more than 2 groups is chi-square test. Then followed by that, we discuss about the cohort study and the relative risk. Relative risk is incidence in exposed by incidence non-exposed. Okay, we calculated it. Do solve some questions based on RR as well. Okay, chalo. Followed by that, we discussed about the ASHA. Okay, village workers, ASHA, Anganwadi worker, trained birth attendant, and village health guide. Okay, we discussed about the population norms and the training duration. Remember ASHA guys, 1 per 1000, but 2 per 1000 is desirable. 10 past 23 8 days. And the functions of ASHA: she's a part of a JSY. Okay, home delivery of contraception, treatment for minor ailments, and the active disease surveillance. Okay, ASHA do not conduct the deliveries. Please do remember this as well. Rabies guys, it's a type of a Lissa virus we have discussed. Case fatality rate of 100%. The intracytoplasmic inclusion bodies are called as Nagri bodies, and the protein that is motor protein that is responsible for the transmission of the rabies virus is dynin. And the first site of rabies bodies to be Nagri bodies to be found is the hippocampus, and the second is going to be cerebellum. Okay, now depending upon the grade 1, grade 2, and grade 3 bites, grade 1 is just a lick on the intacted skin, whereas grade 2 is the scratch, and grade 3 is the blood coming out. Okay, now followed by that, we have discussed the rabies vaccination schedule. If it's a pre-exposure, we are giving a 3 doses. What are these 3 doses? So day 0, 7, 21 or 28 will be the booster dose. Okay, post-exposure prophylaxis or intramuscular, we give a SN regime which is containing 5 doses: 0, 3, 7, 14 and 28. We have a 3 Red Cross regime for intradermal, which is 0, 3, 7 and 28. Okay, post-exposure prophylaxis, less than 3 months guys, nothing to do, no intervention to be done. Wash the wound. More than 3 months, give 2 doses, that is 0 and 3. Bache, that is 0 and 3. Please remember. Followed by that, we discuss about the sequence of an demographic cycle phases. We have high stationary, followed by early expansion, late expansion, and then low stationary or the reversal. Clear? And this has been the question asked in the previous NEET PG exams sequence. Then we discuss this ANOVA test having a quantitative data of more than 2 groups. Chalo. Triage we discuss: red, yellow, green, black. Red given a highest priority, yellow given a medium priority, green a low, and black a least priority. Okay, we talked about the vaccine strains. We have influenza, yellow fever 17D, Japanese live, SA 1414-2, killed Nakayama, BCG, Danish 1331, chickenpox, Oka, rubella, RA27-3, measles, advanced Zagreb, mumps, Jarelin. Okay, and chickenpox, Oka. We discussed about demographic processes: mortality, marriage, migration, fertility, and social mobility. Okay guys, these are some things in the PSM you have to remember. There is nothing conceptual we can made in these things. What are the 5 demographic processes? Just remember these things. Okay, wherever conceptual is needed, where you need to use your concepts, some diseases, maybe the clinical features. Okay, so that time we can discuss, but here you need to remember the formulas. Okay, the numerical questions do come before They were not supposed to come, but now these days at least 3 to 4 questions they usually ask. Okay, normal, relative risk, animal growth, okay, crude birth rate, crude death rate, what is the current MMR, because as per the recent data 2025, a lot of updates have been there. I've already mentioned the new values. Okay, followed by that we discuss about the four principles of the family health, four principles of the primary healthcare. We have equitable distribution, community participation, we have intersectional coordination, and appropriate technology. Okay, then followed by that the adverse effects of the vaccines, where the main one was the intersusception. Please do remember GBS well as well, because they will mention a patient as having areflexia and the gait instability. Yes, I will share the PDF in the MeduHub group. OB-GYN part 1 part 2 is already there. PSM part 1 is also there. I'll share the PSM part 2 as well. Okay, about the pedia, yes, I'm taking the pediatrics on the 16th of July. Okay, 4 hours we'll take a full pediatric session, don't worry. Okay, then we discuss about the intrauterine contraceptive devices, the absolute contraindication and the relative contraindication. Please do remember, this can be the question asked along with the side effects. This side effect question was asked that okay, patient was complaining of bleeding after the delivery, okay, and the bleeding after, sorry, bleeding after the post IUCD. Okay, and what will be the management? So reassurance and folic acid at least for 3 months. Give folic acid at least for 3 months. Okay, now let's have a small break, and followed by that we will discuss the remaining part. Okay, we'll discuss the remaining part after the break, and then in the end I've summarized all the agents and vectors in the one page of the disease, because last time they asked about the Sutsugomoshi, okay, and mite. Okay, so just a small break and then we finish up. Okay guys, chale, have a small break and then we start. Chalo. Yes, guys, I'm audible. Let's start again. Let's start with the next question. Please update me in the comment section. I'm audible. So let's start with the next question. In a disaster management, or all true except? Chale. In a disaster management, or all true except? Okay. Yellow color is the medium priority. Yes, that's right. Gastroenteritis is the most common infection after the disease. Yes. Most common infection after the disaster is the gastroenteritis. If the question is most common zoonotic disease, that's going to be the leptospirosis. Most common zoonotic disease after disaster. Most common zoonotic disease after the disaster, that is going to be the leptospirosis. The answer for that particular thing is going to be the leptospirosis. Leptospirosis. Chale. Okay, response is a pre-disaster. Nahi bache, sir, response is going to be the post-disaster. All given options are true. So the answer is going to be except response is a post-disaster. Response is the post-disaster. Okay, now if we talk about the disaster management, first of all we have mitigation. Okay, risk assessment, prevention. Okay, followed by that we have preparedness. Okay, disaster strikes, then we have response and rehabilitation, then reconstruction. So pre-disaster, these are the pre-disaster activities, and these are the post-disaster activities. So simple question, guys. The response is pre-disaster phase. No, sir, it is a post-disaster phase. It is going to be the post-disaster phase. Clear? Okay, now let's move to the next question. Very important question. Please read the question carefully and then answer. Okay, I'll be checking all the answers in the comment section. A 42-year-old man with a small bowel fistula has been receiving the total parenteral nutrition with standard hypertonic glucose amino acid solution for 3 weeks. The patient is noticed to have a scaly hyperpigmented lesions over the acral surfaces of the elbows and knees, which is similar to the enterohepatic acrodermatitis. What is the most likely cause of the condition? Please answer me the given question. A 42-year-old man with a small bowel fistula. Patient is receiving the total parenteral nutrition, guys. There is a scaly lesion over the acral surfaces of elbows and the knees, and the condition is similar to the acrodermatitis, enteropathica or enterohepatic acrodermatitis. What is the most likely cause of the condition? Write down the answer in the comment section, everyone. Write down the answer in the comment section, guys. Yes. Yes, what is the answer, everyone out there? Guys, look at the age. 42-year-old, number first thing. Number second thing, the question mentions it is not a enterohepatic acrodermatitis. It is similar to that. So if you are marking zinc, that is a wrong answer. This is the given image. Okay, this is the condition. And the acrodermatitis enteropathica, that's usually seen in the infants, children's. Yes. So what will be your answer? Chale. Copper deficiency? No, sir. Copper deficiency is going to be the Menkes disease. Okay, and Menkes disease mein patient will have mental retardation. Patient will have a mental retardation. Patient will have a mental retardation, and patient is going to have a kinky hair. Patient is going to have a kinky hair. Along with that, sir, the enzyme deficient in the Menkes disease is going to be the lysyl oxidase. Okay, Then we have a zinc deficiency, that is acrodermatitis enteropathica. That is acrodermatitis enteropathica, and zinc deficiency causes delayed wound healing. So it causes delayed wound healing and also infertility. Okay, now followed by that, what will be the answer for this particular question? Yes, exactly, sir, it is due to the essential fatty acid deficiency. Now if we talk about an essential fatty acids, if we'll talk about essential fatty acids, what are the essential fatty acids, main ones? Okay, so we'll have number first one, we have linoleic acid, we have linolenic acid, we have linoleic acid, we have linolenic acid, and we have docosahexaenoic acid, DHA. We have docosahexaenoic acid. Okay, now if we talk about linoleic acid, so what is the richest source? It is going to be safflower oil. If we talk about the linolenic acid, that is going to be flaxseed oil. And docosahexaenoic acid, so the richest source is going to be the breast milk. Richest source is going to be the breast milk. Okay, so flaxseed oil, okay, safflower oil, and breast milk for DHA. Okay, for DHA. And if there is a deficiency of this essential fatty acid, that will lead to the thick dry skin called as phrynoderma. Okay, so this condition is called as phrynoderma, and it is due to the decreased essential fatty acids. So deficiency of fatty acids will lead to the phrynoderma. Clear? Okay, so what is the answer? Essential fatty acids. Okay, chalo. For a pregnant woman, what is the ideal antenatal visits? Okay, so ideal antenatal visits for the pregnant woman, that is going to be at least 12 to 14. Okay, if we talk about minimum antenatal visits, minimum as per government of India, so minimum antenatal visit is going to be 4. Sir, minimum as per WHO, that is going to be 8. Minimum as per the WHO, that is going to be 8 visits. Okay, minimum as per the WHO, that is going to be 8 visits. Okay, now let's discuss about how exactly we need to give these 12 to 14 visits. Okay, now if we talk about every month if we talk about first 7 months, that is every month till 7 months, that's going to be 7 visits. Followed by that, we have every 15 days, 8 months. Then we have every week in 9 months. So total of, that's going to be 7 plus 2 is 9 plus 4 is going to be around 12 to 14 visits. Clear to everyone? And in pregnancy, my dear students, in pregnancy, plus 350 kilocalories. Okay, and in lactation almost plus 600 kilocalories. ठीक है ना, यहाँ पे लिखता हूँ सर लैक्टेशन में plus 600 kilocalories for first 6 months. Followed by that we have 550 calories 6 months onwards. Okay, clear? Chale. A 26-year-old male presenting to you with a fever, chills, night sweats and diarrhea. The physician is suspecting the malaria and sent a blood sample for the diagnosis, and dipstick test was performed for rapid diagnosis of Plasmodium falciparum. It's based upon the which protein? It's based upon the which protein? Okay, so tell me guys, which protein? We have a rapid diagnostic test. Which protein is there? Yes, very good. So that's going to be the histidine rich protein. Now let's talk about malaria, guys. The agent for malaria, it is going to be Plasmodium falciparum. It's going to be Plasmodium falciparum. It's going to be Plasmodium ovale. It's going to be Plasmodium vivax. Is going to be Plasmodium malariae. Okay, so we have vivax, falciparum, ovale and malaria. Okay, now if we talk about the diagnosis, we have peripheral blood smear. We go for the peripheral blood smear, and so this peripheral blood smear, we are going to take the two smears. One is going to be thin and next one is going to be thick. The thin will tell me about the species of the malaria, and thick is going to tell me about the confirmation of the malaria. Okay, so write it down guys. So we are going to have two slides. So one is going to be thin, next one is going to be thick. One is going to be thin, next one is going to be thick. Okay, thin is one who tells me about species of malaria, and thick will tell me about the confirmation of malaria. Thick will tell me about the confirmation of malaria. Clear? Yes, chale. Followed by that, we have also the rapid diagnostic test. And who is going to take this peripheral blood smear? Multi-purpose worker male at PhD. Okay, then we have a rapid diagnostic test. We have a rapid diagnostic kit. Okay, and it detects antigen. Which protein? HRP, histidine rich protein, and one more is LDH. Okay, so we have histidine rich protein and we also use LDH, lactate dehydrogenase. Okay, so that is about malaria. Now if we talk about the treatment of the malaria, the question that they usually ask in northeastern states and in the other state. In northeastern states we have ACTL. Okay, so what are the drugs in the ACTL? We have artemether, we have plus lumifantrin, we have lumifantrin, plus we have primaquine. Okay, that is ACTL, artemether, lumifantrin and primaquine. Other states we have ACTSP, we have artesunate, plus we have sulfadoxine, plus primaquine. So that is about northeastern states and other states. Okay, but this treatment they will usually ask bache in case of falciparum. This treatment they will usually ask when they mention Plasmodium falciparum. And sir, if it is Plasmodium ovale, then the drug of choice is going to be chloroquine for all states. Then the drug of choice is going to be chloroquine for all the states. Then the drug of choice is going to be chloroquine for all the states. Okay, chale. Now malaria with pregnancy. Now if Plasmodium vivax is there, if Plasmodium vivax and if Plasmodium falciparum. If Plasmodium vivax, again the drug of choice is going to be chloroquine in pregnancy in all trimester. Chloroquine, that is in all the trimester. Okay, and if it is Plasmodium falciparum, the first trimester, we are going to give the quinine. The first trimester we are going to give the quinine. Okay, and the second trimester onwards, if northeastern, so then I will give ACTL. If other, I'll give ACTSP. That is about the malaria in pregnancy. In pregnancy, primaquine is contraindicated. Please do remember, primaquine contraindicated. Contraindicated drug is going to be primaquine. Primaquine is contraindicated. चले आगे बढ़ते हैं. Now prophylaxis of malaria. Okay, now usually guys in general we'll write what are the prophylactic drugs that we start prior to the place, that we start prior while going to the places having malaria. Northeastern, usually sir, we usually take 2 weeks before and 4 weeks post return. Okay, what are the drugs? So we are drugs having doxycycline. We are having a drugs like doxycycline, mefloquine. We have doxycycline, mefloquine. We have atovaquone as well. These are the prophylactic drugs. Okay guys, if in detail they can ask, you can mention that doxycycline usually in a short prophylaxis. Okay, mefloquine usually in the long-term prophylaxis. Clear to everyone? Yes, clear to everyone? Chale guys. Okay, so that is about the prophylaxis of malaria. So remember guys, treatment in case of a northeastern state it is ACTL. In case of an other state it is ACTSP. Okay, malaria in pregnancy, if Plasmodium vivax is there, chloroquine is going to be the drug of choice for all trimesters. And if falciparum is there, the first trimester is going to be quinine, and second trimester onwards, if northeastern state is there, ACTL. If other, that is going to be ACTSP. Okay, prophylaxis of malaria, 2 weeks prior to the 4 weeks post return you'll give. What are the drugs? We have doxycycline, we have mefloquine and atovaquone. Short-term prophylaxis doxycycline, long-term prophylaxis we use mefloquine. Okay, next question was asked, recent transmission of malaria can be calculated from. So recent transmission of malaria can be calculated from. Write down in the comment section, bache. What will be the answer for this? Recent malaria transmission. Recent transmission of malaria. Recent transmission of malaria can be calculated from. What will be the answer, bache? Yes. Chalo, that is going to be IPR, infant parasite rate. What will be the answer? Infant parasite rate. So let's discuss about the indicators. Now first one, API, that is going to be annual parasite incidence. What is annual parasite incidence? Number of new malaria cases. Number of new malaria cases per 1000 population. Number of new malaria cases per 1000 population. Okay, what is the significance of this annual parasite incidence? So the significance is it tells me about the active disease transmission. It tells me about the active disease transmission. Next one is infant parasite rate. Infant parasite rate, it's the best indicator of recent malaria transmission. Best indicator of recent malaria transmission. Okay, next is annual blood examination rate. Okay, it's the best indicator for that's the best indicator for operational efficiency of worker. Operational efficiency of worker. Okay, and we have slide positivity rate. It tells us about the percentage of slides examined. So these are about the indicators of the malaria. Okay, so we have API, which tells us about the active disease transmission. We have infant parasite rate, recent transmission, ABER, operational efficiency of the worker, and the percentage of slide examined, slide positivity rate. Next, a woman who is lactating came to the OPD 6 weeks after the delivery for the checkup to get an advice for the contraception. Which of the following you will not advise? Okay, what will be the answer for this particular question, Gache? Yes, a woman is there. She is asking for the contraception. She is lactating. And which of the following you will not advise? Very good, sir. Combined OCP will not advise because it is contraindicated in lactation. That's why in the lactation, the preferred contraceptive we give is progesterone only pills. That is going to be progesterone only pills. Okay, now two things are there. If lactating, okay, contraindicated OCP for 6 months. If not lactating, remember, contraindicated for 6 weeks. Is that clear? So that is about the OCP and lactation. Okay, what is the preferred one? Okay, preferred as progesterone only pills. Preferred as progesterone only pills. Okay, now if we talk about the combined OCPs, these contain estrogen plus progesterone. So they contain estrogen plus progesterone. Okay, they contain estrogen plus progesterone. Okay, now what are the contraceptions they tell? Mala N and Mala D. Mala N and Mala D. So they have estrogen there, ethinyl estradiol. Which estrogen, sir, they have? Ethinyl estradiol plus, and they have levonorgestrel. They have ethinyl estradiol and they have levonorgestrel. Okay, how much of ethinyl estradiol is there, sir? 30 micrograms. How much of levonorgestrel? 150 micrograms. Okay, so that is about the combined OCPs. Okay, now Mala N, guys, it's a free of cost, and this is around 2 to 3 rupees. Okay, Mala D is around 2 to 3 rupees, and this Mala N, it is free of cost. It is free of cost. Okay, now OCPs with cancers. Now OCPs decrease some cancer and OCPs increase some cancer. Now what are the cancers that OCPs increase? Number first one is going to be hepatic adenoma. If the question will be asked the most common cancer associated with OCPs, your answer is going to be hepatic adenoma. Okay, number second is going to be cervical cancer, and number third one is the breast cancer. So we have hepatic adenoma, followed by that we have cervical cancer, and we have breast cancer, and we have breast cancer. Okay, what are the cancers which will be decreased with the OCP usage? Okay, now first cancer, that is going to be endometrial cancer. Now first one is going to be endometrial cancer. Okay, followed by that we have ovarian cancer, and then we have uterine cancer, and then we have uterine cancer. We have endometrial cancer, okay, we have ovarian cancer, and we have uterine cancer. Okay, now this endometrial cancer, sir, question was asked, it is increased due to one drug. What is the name of the drug? It is increased due to the one drug which is called selective estrogen receptor modulator. The name of the drug is tamoxifen, which is used in the breast cancer. Okay, and the alternative for that particular drug is raloxifene, and this raloxifene is also used in osteoporosis. This tamoxifen causes endometrial hyperplasia. क्या करता है cause? Sir, it causes endometrial hyperplasia. It causes endometrial hyperplasia. Is that clear? Is that clear? So that is all about the OCPs which increase some cancer and the OCPs which decrease some cancer. Okay, chale, clear? Okay, next is contraindication. Next is about the contraindications. Okay, now we have absolute contraindication and we have relative contraindication. We have absolute contraindication and we have relative contraindication. What are the absolute contraindication? Number one, as it causes the hepatic adenoma, so contraindication will be liver disease. Followed by that, sir, pregnancy. Followed by that, CVD, cardiovascular disease, or thromboembolism. So what are the relative contraindication? Number one, age less than 40. Okay, so we have renal disease. So we have lactation, diabetes, migraine, hypertension. Is that clear? So these are the absolute contraindication and relative contraindication. Okay, so this was all about OCPs. Okay, so combined OCPs, we have one regime. Can you name the regime that we use for the combined OCPs? What is the name of the regime? So the name of the regime is going to be the, yes, the name of the regime is going to be USP and Lancy regime. What is the name of the regime, bache? The name of the regime is USP and Lancy regime. Clear? Chalo. Which of the following does not show iceberg phenomena? Which of the following does not show the iceberg phenomena? Write down in the comment section, guys. Which of the following does not show the iceberg phenomena? What will be the answer? Chale, let's discuss the disease that show the iceberg phenomena and does not show the iceberg phenomena. Okay, now this is the iceberg. Okay, this visible part are the cases which are visible cases and they are diagnosed cases. They are clinically diagnosed cases. Okay, and this line is the demarcation line. So this is the demarcation line between the apparent and the non-apparent cases. Okay, it is the demarcation line between apparent and non-apparent cases. Clear? This surrounding water is going to be healthy population. Surrounding water is healthy population, and these submerged part are the hidden cases. Okay, these are the cases which are asymptomatic, which are pre-symptomatic, which are undiagnosed, latent, or which are deliberately ignored cases. Okay, now the disease that show the phenomena, the diseases that show the phenomena, which means the submerged part. Okay, and disease that not show the phenomena, they are the visible part. Okay, now disease that show the phenomena, we have HIV, we have malaria, cholera, we have diphtheria, we have polio, and typhoid. Okay, now the disease which do not show the phenomena, we have rabies, tetanus, measles, we have pertussis. Okay, these are the disease that do not show the phenomena. Okay, so the question is, which of the following does not show the iceberg phenomena? Your answer is going to be rabies. Your answer is rabies, and rest everything about the rabies we have studied. Everything about the rabies we have studied as well. Okay, chalo, next question, guys. About the biomedical waste management, you already know that we have 4 bins, yellow color, and in yellow color we'll put all the non-recyclable infectious waste. What usually we'll put in yellow color? Non-recyclable infectious waste. Non-recyclable infectious wastes like human tissues, okay, organ body parts like placenta and all. Okay, we have animal carcasses, body parts, organ tissues, contaminated item with blood and body fluid. We have cytotoxic drugs, antibiotic, we have used chemicals, we have liquid waste, discarded mattresses, bedding, okay, and the blood bag, okay, laboratory culture, specimen, they will all go into the yellow color. Okay, for yellow color we go for incineration. Incineration, temperature of 12 degrees Celsius. Okay, then all the plastic items, okay, tubings and all, they will go into the red color, like tubing bottles, IV tubes, sets, catheters, urine bag, syringe, without needles, vacuum and their needle cut and gloves. Okay, they will all go into the red color. Followed by that, all the infectious sharps will go into the white color, like needle, syringe with fixed needles, needle from the needle tip, cutter, burner, scalpel, blade. They will all go into the white color. Okay, and for white color we use a screw feeder for disinfection. Screw feeder. And then all the glass items discarded or broken, okay, metallic body implants like pacemakers, okay, they will all go into the blue color. They will all go into the blue color. Clear? So this is all about yellow, red, white and blue. Remember guys, black color we put the general waste. Black में क्या जाता है? Black general waste. That is about the black color, general waste. Clear? Next is going to be the mission Indradhanush. Okay, this mission was launched 25th of December 2014, and usually the beneficiaries were the age group 0 to 2 years and the pregnant ladies. Okay, now the following vaccines were given under this program, Mission Indradhanush. Okay, now first there were only 7 vaccines, then followed by that 4 more were added, and followed by that 2 more were added. Now what exactly are these vaccines? Okay, first vaccine we have 7. We had BCG. Okay, we had BCG, then diphtheria. We had BCG, diphtheria, pertussis. Okay, then we have tetanus, we have OPV, we have Hep B, and we have measles. So these are the vaccines, first 7. Then 4 more vaccines. We have Japanese encephalitis, we have IPV, we have Rota vaccine, and we have MR. Plus 2 more vaccines. We have pneumococcal vaccine and influenza B. So this is all about the Mission Indradhanush. The question that they can ask, बच्चे, which of the following vaccine is not included? Which of the following vaccine is not included under Mission Indradhanush? Okay, one more mission is there, Mission Abhiyan Indradhanush. Okay, okay. Mission Indradhanush and Abhiyan Indradhanush. That is for the occupational disease, lead poisoning and all. Chalo. Now the last one guys, about the diseases and the agent and the vector. Okay. Now if I talk about the first disease, that is the brucellosis. Okay, brucellosis usually due to the unpasteurized milk, goat milk, and we have 2 tests that we do in the brucellosis. One is going to be Rose Bengal test, another is going to be the milk ring test. And in this brucellosis the patient will complaining of the swinging fever. ठीक है ना, patient को कौन सा fever होता है brucellosis में? Swinging fever. Okay, चलो, what is the agent name? Sir, B. melitensis. B. melitensis, and the vector is going to be unpasteurized goat milk. Vector as unpasteurized milk. Number second one is Carnosaur forest disease, KFD. Agent is group B arbovirus. Agent is group B arbovirus. Number second, sir, the tick, hard tick. Inside the India, outside the India it's soft tick, but you remember the inside India. Okay, yellow fever, again that is going to be group B arbovirus. Group B arbovirus. The question has been asked about a yellow fever vaccination. That vaccination certificate is valid after the 10 days of administration till the lifelong. Please remember, after 10 days of administration. This has been the question asked. The vector is going to be Aedes mosquito. The vector is going to be Aedes mosquito. Okay, we have leptospirosis, most common zoonotic disease after the disaster, usually due to the rat urine. Okay, so it is L. interrogans as the agent and the vector is rat urine. The vector is rat urine. We have echinococcus, that is echinococcus granulosus. Okay, the vector is dog. The vector is dog. We have teniasis. We have Taenia solium and Taenia saginata. Okay, and the vector is pork and beef. Remember, they causes the neurocystic causes. Drug of choice is going to be albendazole and the steroids. Starry sky appearance. Followed by that, if there is teniasis, the drug of choice is going to be niclosamide and praziquantel. Okay, if we talk about the plague, the agent is Yersinia pestis. The agent is going to be Yersinia pestis. Okay, and the vector is rat flea. The vector is rat flea. Okay, the most severe form of most common type of the plague is going to be bubonic plague, but the most common is going to be pneumonic plague, and most severe is going to be bubonic plague. Okay, drug of choice is going to be injection streptomycin. For the prophylaxis, we give tetracyclines. Okay, that is about the plague. Okay, malaria, you already know, guys. Plasmodium is agent. Plasmodium as the agent, and the vector is Anopheles. Vector is Anopheles. Okay, followed by that, we have a rabies. Virus is going to be Lissa virus. Okay, and the vector is a rabid animal. Rabid animal. Okay, dengue, again group B arbovirus. Okay, and the vector is Aedes. Aedes. We have epidemic typhus, Rickettsia prowazaki. And we have vector as louse. We have epidemic typhus, Rickettsia typhi, and then vector as flea. Okay, we have scrub typhus, Rickettsia sutsugumoshi. We have Rickettsia sutsugumoshi. And vector as mite. Vector at mice. Okay, so this was all about the agent and vectors. Now let's finalize it with the rickettsial fever, bache. Rocky Mountain spotted fever. The vector is hard tick. Okay, remember rocks are hard, so hard tick. And the agent is Rickettsia rickettsii. Rickettsia rickettsii. The Indian tick typhus, the agent is Rickettsia coroni. Okay, and again the vector is going to be hard tick. We have Rickettsia pox, Rickettsia acari, and the vector is going to be mite. Okay, so that's all about the agents and vectors. Is that clear? Okay, so that was all about a part 2 PSM, guys. I've tried to include all the topics. Okay, still more topics are there, but based upon all the previous year questions and topics, I've included everything. So do revise it, part 1 and part 2. I hope the session was helpful enough, and on the 26th of July we'll get as many questions as possible. So do revise Obikani part 1, part 2, PSM part 1, part 2. Any doubts, any queries related to these two topics, these two subjects, you're always welcome. On 16th we'll do the pediatrics part 1, just full pediatrics. There is no part 1, part 2, just 4 hours pediatrics session we'll do, including all the previous year questions and the most important topics. Okay, so do remember the rabies vaccination schedule that we have studied today. Okay, do remember about the vaccinations. This disaster phase sequence was also asked in the previous year NEET PG exams. So it was mitigation, then preparedness, response, rehabilitation, and reconstruction. Remember, the most common infection is going to be gastroenteritis. All the recent data questions, guys, remember that as well. Vitamins, essential fatty acid deficiency is very important. Malaria, please do remember, guys. Okay, do study about HIV as well. sexually transmitted diseases as well. Okay, so any question related to these following topics that we have included, you're always welcome. Clear? So guys, all the best for your exams. Do revise, don't compare your knowledge with anyone. Okay, and if you have any doubts, okay, feel free to ask. I hope session was interactive enough. Anything to ask, you guys can write down in the comment section. About the PDF, I'll share in the group. Okay, about this PDF part 2 I'll share in the MeduHub channel. ठीक है, चलो. So I'll see you on the pediatrics of 16th of July. Till then, take care, study well, okay, and all the best. Thank you. चलो guys.